Okay, testing, testing, testing. One, two, three, four. Testing, testing. No, John Michael, today is Sunday. Just a moment. If you can chill with the stomping on the floor. If you can stop stomping on the floor. Well, it's none of your business, John Michael. Testing, testing, testing. Okay, I'm going to begin at image image 34, which I believe is page 368. Leads, as previously discussed, inadvertent patient disconnection and leaks in the patient ventilator circuit are common during mechanical ventilation. When these situations arise, when these situations arise, low pressure, low volume, low VE or apnea alarms usually become activated. Volume time scalars are one means of identifying leaks, as are pressure, volume, and flow volume. Flow volume leaks. See figures 910, 933, and 9-4. Graphic representation. The most important indicator of a leak can be found using the expiratory volume curve. If the expiratory volume does not return to zero in any of these waveforms, a leak is present in the system. Figures 18.6 and 18.7, 18-4, and 18-5. In some cases, the volume tracing may drop below zero. This finding indicates that the equipment needs to be recalibrated. See figure 18.1. This also can occur if the patient is actively exhaling. Inadequate flow. Patient ventilator asynchronous can occur if a ventilator provides only a fixed flow during mechanical ventilation. In such cases, the pressure time graphic is concave and the flow curve is constant. See figure 18.3. Inadequate sensitivity setting for patient triggers. The ventilator's trigger sensitivity can be set too low for a patient, as an appropriately set sensitivity, like an inadequate flow setting, increases WOB. Overinflation. Pressure volume loops that produce a duckbill or peak appearance can be used to identify alveolar overinflation. Ventilator graphics can be used to detect auto. If expiratory flow does not return to zero before the next mandatory red auto peak is present. Okay, inadequate inspiratory time during pressure ventilation. Inadequate inspiratory time during pressure ventilation. One goal of pressure control ventilation, PCCMV, may be to provide a T1 long enough to achieve a slight plateau effect. Respiratory flow drops to zero before the end of inspiration. Figure 5-2. Was not present, but because of changes in the patient's lung characteristics or a short T1, figure 5-2, the T1 may need to be adjusted depending on the clinical situation. Okay. Then we have the two figures. 5 continued E, apnea line, and then F, loss of power line. So severe E, stability and adequacy of ventilation. So apneic episode occurring? Yes, readjust ventilatory support to protect the patient. No. Is the alarm setting inappropriate? Yes, reset the alarm? No. Is the ventilator insensitive to patient's effort? If yes, reset the sensitivity. If no, is the leak present? Is the section of low pressure line? If, if, if no, is the flow or pressure sensory faulty? If yes, clean, recalibrate, check, and replace sensor if necessary. If no, check the operator's manual and or contact the training technician. And F says, verify patient stability and adequacy of ventilation. Is there electrical power failure? If yes, we have five selections here. It says, is unit plugged into AC outlet or is external battery functional? 2, is power switch on? 3, try resetting the switch. 4, check circuit breakers and fuses. 5, provide backup power source. If no, is there a pneumatic power failure? If yes, you have 4 selections. Connected to high pressure outlet, line faulty, is the power source pressure adequate, and check ventilator. If no, it says, is the battery power low? If yes, reconnect to alternate power source and replace recharge battery. If no, check operator's manual and or contact. Then we have the next page. When lower pressure delivery are very high at the beginning of the breath, particularly a pressure breath, a phenomenon known as ringing, spiking, or overshooting can result in oscillation of air in the patient ventilator circuit and the upper airway at the beginning of inspiration. Figure 18 now. This situation, although not life-threatening, does not represent a smooth breath delivery. Current ICU ventilators use easier to ventilate for the circulatory error. Then we have figure 18.6 in the loop A, and then flow volume loop B, indicating an air loop. Volume loop, the y-axis pressure on the x. A and B just has like a weird, like two kind of shape. You have figure 18.7 flow time curve demonstrating a problem. Problem solving using ventilator graphics. Respiratory therapy is a low pressure ventilator alarm for a patient DMD. She evaluates the patient and finds that the individual is not in distress and is being ventilated and oxygenated. She checks the activated alarm, i.e. low BE, silences it, and saves the graph display. Figure 18.7 shows the saved graph. What do the waveforms indicate? have case study 18.5, evaluating the ventilator problem. Of UCCMB, the 10 centimeters of water of P. The respiratory therapist noticed the volume time graphic shown below. During exhalation, the respiratory therapist feels an uninterrupted flow of a small amount of air, even though the patient has had no previous evidence of air trapping. What do these findings suggest? So it shows volume time curve in which the volume curve descends at the beginning of exhalation and then slowly rises during the start of the next respiratory phase. Okay. So page 37 allows adjustment of gas flow and pressure delivery at the beginning of a breath to help taper flow and pressure delivery and reduce overshoot. The feature commonly is labeled the inspiratory rise time. Oscillation also can occur if condensation is present in the patient's survey. The latter situation can be easily remedied by draining it. Section, explanatory portion of volume time curves below baseline. In patients with air trapping, active exhalation may cause the expiratory portion of the volume time curve to drop below baseline. The curve also may descend below baseline if the expiratory flow sensor is out of calibration. See figures 18.1 and 18.3. Patient ventilator asynchrony. Figures 18-3 and 18.10 show graphics for patient breathing out of synchrony with the ventilator. As mentioned earlier, patient ventilator synchrony can occur with low insensitivity, symptoms are inadequate, and when ROP is present. Parameters for switching to a circle controlled mode, pressure regulated volume control, or ventilation may help to alleviate the problem. The patient may also need to be sedated. Next section, unexpected ventilator responses. Problems in some microprocessor controlled ventilators can result from inappropriate use of the sequences associated with the machine. The following section discusses a few noteworthy situations. The intent is not to criticize any particular ventilator, but rather to make the reader aware of situations that have been reported, including unseating of exhalation valve, excessive CPAP / peak levels, changing the sensitivity, inability to trigger air pressure support of breath, and altered alarm function. Then you have two figures. Figure 18A that says flow volume reflecting the presence of auto peak. The arrow indicates the amount of flow at the edge of exhalation. Then you have figure 18.9. Flow time and pressure time curves demonstrating no pressure supported breath. Flow time and pressure time curves reading oscillation. Phenomenon that occurs with an overshoot of flow and pressure at the beginning of expiration. Okay, page 371 of chapter 18. Or obstructed expiratory valve The expiratory valve can be unseated if it is blocked to obtain astatic compliance, or CSV. This generally is a problem only if the ventilator does not have respiratory pulse control. The valve is unseated because a pressure buildup during the procedures causes the exhalation valve to disengage. An unseated expiratory valve may be the cause if the vent is out of alarm. A low pressure alarm or a low CPAP/peak alarm activates and the patient has difficulty breathing. It is important to mention that these same alarms can be activated by other factors. Therefore, the actual cause must be established. Expiratory valves may also malfunction if they become obstructed or their mobility is impaired by accumulation of residue from medications delivered by small body nebulizers. The valves can be protected by placing bacteria filters in mind before the exhalation valve. Expiratory filters must be changed frequently to avoid increased expiratory resistance. Excessive CPAP peak levels. High dose set blood operators can occur in certain clinical situations. Example, potential problems that could occur with PSP. This doesn't accidental delivery of high blood pressure because of leak in bleeding circuit beyond the burden void increases the peak can also occur in tracheal cup leak is present. In this latter case, the ventilator attempts to compensate controls application of high flow to maintain CPAP peak levels can cause the airway pressure to rise and the patient may develop dyspnea, tachypnea, and tachycardia. This problem can typically be solved by limiting use. Another problem that involves patient circuit leaks can occur during PSV. Reported with the Puritan Bennett 7200, Copenhagen, now core Puritan Bennett, with a leak of more than 5 liters per minute felt around the cuff or somewhere in the patient's circuit. The set PSV level will be maintained through the leak throughout the cycle, causing CPAP to develop. A drop in flow to 5 liters per minute is the known mechanism that stops the PSV respiratory phase in this ventilator. All ventilators with PSV now have safety mechanisms. If the T1 exceeds a preset time around 3 to 5 seconds, the ventilator will cycle into expiration. Nebulizer impairment of patient's ability to trigger a pressure support crack. During PSV, the patient must create a slightly negative pressure or drop in flow in the circuit to initiate a breath. Flow nebulizer is placed between the patient and the sensing mechanism. The patient often finds it more difficult to generate the effort to trigger the ventilator. Devices that sense ventilator triggering usually are on the inspiratory side of the ventilator. Difficulty is especially apparent in older patients with COPD and with respiratory efforts. Note, this problem may arise with microprocessor controlled ventilators whenever a nebulizer powered by an external gas source is used. Triggering difficulty may also occur with patients during the assist control AC mode when an external nebulizer is added in line and may not be significant. Set rate and volume ensure where the patient will receive an adequate does not trigger the breath. Is not a backup rate with PSV and providing support ventilation. Therefore, clinicians should use only the nebulizer provided by the ventilator manufacturer. If one is not provided, practitioners should use an MRU or dose inhaler over this basis, an ultrasonic nebulizer, or a vibrating mesh nebulizer. High tidal volume delivery. Volume delivery can occur when externally powered small volume nebulizers are used for aerosol delivery. Add extra flow to the patient's circuit, which can increase the deliverability and result in artificially high readings of exhaled PE. Although this is not a significant problem in most adult situations, it can be very significant in neonates, and these devices should not be used for medication delivery during neonatal mechanical ventilation. High PT delivery also can occur in ventilators that allows patients to receive additional flow during inspiration on demand. For example, concurrent ICU ventilators provide additional flow for airway pressure grabs H2O. This results in a higher than the set value. Set values therefore actually represent minimum PT delivery. Patients can receive the volume of air they want. Alter alarm functions. Some monitoring devices will operate on optical detectors. Exposed to intense light, such as sunlight through a window, the alarms may sound even though no change has occurred in the patient's status. This may happen with volume monitors, pulse oximeters, and similar light-sensitive devices. Electromagnetic interference. Electrical devices that emit radio frequencies, such as cell phones, can interfere with the operation of medical equipment. Hospitals generally prohibit the use of cell phones, walkie-talkies, and similar equipment in locations such as the ICU, where problems are likely to occur. These devices have been known to interfere with the function of mechanical ventilators, infusion pumps, smoke detectors, and telemetry equipment. Other medical devices that can be affected include ECG monitors, oxygen apnea monitors, defibrillators, blood warmers, and dialysis units. When the purchase of a piece of equipment such as mechanical ventilators under consideration, the hospital should determine. We go to 30. Determine what built-in safeguards the manufacturer has prolonged to prevent electromagnetic interference. Then we go back, we have one figure. 10 says white fluctuations can be seen in the pressure time curve when the patient is actively breathing during mechanical ventilation, but the ventilator is not set up to respond to patient demand. Ventilator asynchronous. The opening manuals for microprocessor control ventilators provide provide information about troubleshooting situations that are unique to the particular ventilator. Okay. established with concrete and other viable solutions. Sudden onset dyspnea can be identified by observing the physical signs of distress, including nasal flaring, diaphoresis, of the accessory muscles of the retraction supernatural, or retraction of the suprasternal, supraclavicular, or intercostal spaces. Paradoxical or abnormal movements of the thorax and abdomen of auscultation. Identifying the cause of patient ventilator symptoms can be accomplished using a relatively simple approach. If the patient is in severe distress, the first step is to disconnect the patient from the ventilator, ventilate the patient using the manual resuscitation bag. When a resuscitation bag is used properly, these devices allow for the assessment of lung characteristics. The most common patient-related problems encountered during mechanical ventilation were airway, pneumothorax, bronchospasm, or excessive secretions. Evaluation of the patient's secretions can be useful in differentiating a variety of patient-related problems. Changes in the patient's positions can be associated with accidental extubation, bending and twisting of the patient's circuit, and in some cases, alterations in patient's level of oxygen. Activation of low pressure, low volume, and low PE alarms typically indicate that a ventilator circuit is present. Circuit leaks typically occur at the level of the ET and at junctions in the patient circuit where two connections exist. In addition to an inappropriate sensitivity setting and inadequate flow, other types of patient ventilator asynchrony modesty, and increased ventilatory drive, or the need for sedation. Activation of apnea alarm may indicate patient apnea, system leaks, inadequate machine sensitivity, or inappropriate set apnea parameters. A low source gas alarm activates if the gas source fails or the high pressure line becomes disconnected from the gas source. The activation of high pressure alarms can be categorized as ear problems, changes in lung characteristics for patient-related conditions, and problems related to the patient ventilator circuit. An error message or alarm or both is triggered if the operator tries to select outside the range of parameters or is incompatible with the other selected settings. Ventilator graphics displays can provide valuable information that clinicians can use to evaluate the integrity of the patient ventilator system. Careful analysis is required to solve patient ventilator system problems and troubleshooting malfunctions. Experience is an important part of the learning process. By using knowledge gained through experience, practitioners can expand their ability to solve a particular problem. There's questions. But so that finishes the broadcast.